And we have started. I'll let you know.
Good morning all. Welcome to Fast Track City 2020 conference being held virtually. Now we have a session on case studies from Asia Pacific region. 3 cities in Asia Pacific region would be presenting their experience of dealing with COVID-19 and how is it that their cities have responded to the pandemic and have been able to present their disruption in the health services, what innovations that they have tried and have been able to maintain and retain the continuity of care for PLHs. We would also be learning from them as to, unique to their own metro cities, how they have been able to deliver the services, have responsive governance in managing these issues during the session, and the 3 case studies we would have from Bangkok, Jakarta, and Melbourne. And myself, Dr. Shrikala Acharya, I'm Additional Project Director at Mumbai District AIDS Control Society. I would be moderating the session. I now request our first speaker, Dr. Thishishant Ayuthia, who is from Bangkok Metropolitan Administration Public Health Center, Thailand, to present his case study.
Good morning, delegations and colleagues. I'm very pleased to be here with you this morning and having a chance to share my experience with you in dealing with TB, HIV, and STI during the COVID-19 pandemic. This is the outline of my presentation. First, I will talk about COVID-19 situation in Bangkok and Thailand. Then I will move on to the situation and the policy concerning TB, HIV, and STI in Bangkok. Next, I will talk about the impact of COVID-19 to our services. Then I will go on to share our solutions to ensure the continuity of the treatment. Finally, I will share some lessons we learned from this situation. First, for the COVID status in Thailand, we first detected COVID-19 cases on January 12th. We are the first country that reported COVID-19 cases outside of China. A few cases were reported daily until 2 months later. We experienced a large outbreak from 2 events. The first was from the boxing stadium cluster. Another outbreak was from nightclub cluster. These slides show the total number of cases of the laboratory confirmed COVID-19 cases in Thailand. As of today, we have a total of 3,447 confirmed cases. The mortality rate is around 1.6%. Also, about 50% of all cases were from Bangkok. Right now, there is no local transmission of COVID-19 in Thailand for more than 100 days. After a week of the first outbreak, the BMA government ordered temporary closure of the premises. Later, the government imposed a countrywide curfew from 10 p.m. to 5 a.m. Then a week later, the government imposed a countrywide lockdown restrictions. Most spaces were ordered closed. During this period, most hospitals in Thailand postponed non-emergency visits to the facilities to prepare for COVID-19 response. Later, from the 2nd of May, the government gradually eased the lockdown restrictions while continuing to enforce the mask wearing and social distancing in the public spaces. This graph shows the laboratory confirmed cases in Bangkok. You can see male are more likely to be infected than female. This due to the outbreak was first started from the boxing stadium and then it spread to the other clusters. The COVID-19 cases in Bangkok are mostly young adults as they have plenty of social activities. From this graph, we see the dark blue bar, which represents boxing stadium outbreak. Later, most of the COVID cases were from contacted with confirmed cases. So I move on to the Bangkok TB, HIV, and STI situation and policy. Bangkok represents around 40% of total new HIV infections in Thailand. New HIV infections has declined 27% from 2010 to 2016. Bangkok is lacking of the rest of the country and the global target of 75% reduction or 800 new HIV infections to attain ending age by 2020. Our current progression to 90-90-90 strategy HIV control target in Bangkok. You can see that we are improving, especially the first 90-90. People living with HIV knows their status, which we have already reached the target. However, we are still lacking in the second and the third 90. So we need to set an interim goals before the fast track target in 2030. This slide shows our strategic plan to end AIDS in Bangkok in the next decade with the following goals. The first goal is to expedite search and service system for all people with HIV to be diagnosed quickly for at least 95%. And the second goal is to increase access to HIV prevention through effectiveness strategies among key population at least 95%. The third goal is to have at least 90% of people living with HIV or AIDS receive an early treatment after diagnosis and improve viral load suppression efficiency. The fourth goal is to promote and protect human rights and gender equality to reduce the stigmatization and discrimination to be less than 10%. And the last goal is to develop a strategic information system that can be used in planning improvement operations and mobilize resources from both the public and private sectors. So we also have a goal to end TB in Bangkok as well. From WHO's end TB strategy from 2016 to 2035, we need to decrease the TB incidence from 126 to 10 cases per 100,000 people. And so we set the goal of 90-90-90 for TB as well. This slide shows the reduction in TB incidence and compare the reduction rate between 2.7% compared with the 12% per year. We need to achieve the reduction of 12% of the TB incident to achieve the end TB goal in 2035. And this slide shows the proportion of TB cases in Bangkok. BMV facility only represents 1/5 of all cases. So I will move on to the impact of COVID-19 to our TB, HIV, and STI services. So during the lockdown, we could not do the outreach program as usual, though we saw a reduction of cases from active case finding. And also we have a large number of COVID-19 cases and PUI cases. We need to divert most of our medical staff or personnel and resources to encounter the COVID-19 outbreak. And for this graph, we can see that the active TB case finding, we can only screen for about half of what we achieved in last 2 years, especially the fourth quarter of this year. And we believe that the reduction of in number of the visits was caused by social distancing policy and change in social and sexual behaviors. The patients also concerned of getting infected with COVID-19 when making a visit to the hospitals. On the other hand, the healthcare workers can spend more time on some cases that were not related to COVID-19 also. But some disruption from the restriction of movement order also caused an increase of number of lost to follow-up patients. For an example, a patient might live in a remote province and could not make a visit to the doctors. And according to the data from the BMA public health centers, you can see there was a declining number of the PEP and PrEP clients after the outbreak and the lockdown in March. And we can also see the rising trend after the easing of lockdown measures. However, there is no disruption in the rising trend of people who need the ARV as usual. This might be due to the patients have an awareness that they need the treatment, and they're still seeking for treatment in this situation. This slide shows the number of new HIV cases that start receive the ARV per year. For the retention in ARV, we also saw the same number of the retention proxy in BMA facilities during the pandemic. We can achieve more than 90% of the patients who are retained in the program. But on the contrary, we saw a lower TB treatment success rate when compared with the past 5 years. Next, we move on to the BMA management during COVID-19 for TB patients. First, we reduce the number of visits at healthcare facilities by extended appointment from 1 week to 2 months. And we also comply with the Thai government policy of social distancing and stay at home ordered by using telemedicine. Usually, BMA endorse DOT for all TB patients. However, due to COVID-19, we need to move to VOT. Also, for the patients who require medical assistance, we encourage more home visits and anti-TB medicine delivery to them at their home. As for people living with HIV, in order to reduce the number of unnecessary visits to the healthcare facilities, we implemented differentiated services delivery. The poster on the right is the new and simple differentiated services delivery guidelines from Ministry of Public Health. And we keep the healthcare workers up to date with the guidelines and maintain the quality of HIV services using the virtual sessions. And the new policy endorsed by the National AIDS Commission to reduce the risk of exposure of people living with HIV to COVID-19 and to reduce the burden on the health system and clinical personnel. Health facilities in Thailand were to dispense the ART to 3 to 6 months doses in order to prevent people living with HIV from running out of the medicine. Some ARVs can run out of the stock due to an export restriction of the other countries. For example, we switched from the stock out single tablet regimen to the multi-tablet regimen. BMA also increased an access point of care for TB, HIV, and STI patients by building more capacity in the public health centers. We provided a one-stop service access point to reduce the hospital visits. You can see on the map, we have a lot of public health centers that can provide healthcare for the HIV and TB and STI together at the one point. And also for the HIV control, we expanded our HIV control effort by providing PrEP, condoms, and STI medication delivery service. We also extended our service hours in the evening. And we also use the social network to outreach to our target key population. You can see on the website, we have the chat room, the private chat room in the platform that target to the young MSM. And for the PrEP clients, even though we saw a decreased number of visits at our clinic, but we expanded our services to ensure continuous access to our services by using the postal service and telemedicine. You can see that we start to send our medications after April to them. And this slide show we use the social network platform like the Line application, the Messenger on the Facebook and Twitter. And another example for our expanded service, we also provide mobile HIV and STI testing service together with the COVID-19 mobile swabbing units. The picture on the left is the COVID-19 investigation in the nightclub area, which has the high concentration of the key populations. And last month, we launched a new 12-month HIV self-test program that targeting MSM and TG populations. And first, they can anonymously request an HIV self-test kit from local pharmacy. And they can perform the self-test by themselves and go to confirm the result with the healthcare professional later. So what we learned from this situation? Even though we could control the transmission of COVID-19, we still experience some form of the interruption in our medical service. Thus, we need to modify our service to be flexible, uncomplicated, and comprehensive. And also together with utilizing more social media platforms. Lastly, I would like to thank the Division of Global HIV and TB Program, PEPFAR US CDC, and UNS Thailand for providing the data. Thank you for your attention.
Thank you, Dr. Thiti Sant, for sharing your experiences of impact of COVID pandemic on HIV, STI, and TB program in Bangkok city. The various approaches, the innovations that you have tried for patient-centric services, including one-stop center using social media outreach, have been quite insightful for its implementation in other cities, including in Mumbai. I thank you sincerely for your presentation. And now I would request the next speaker from Jakarta, Dr. Vidya Stuti, who is from Jakarta Provincial Health Office, Indonesia, to share her presentation on their experiences of the pandemic and its impact in Jakarta city. Thank you.
Thank you. Good morning, Dr. Archarya. Ladies and gentlemen, thank you for the opportunity for Jakarta Provincial Health Office to participate in this precious conference. And I'm Dwi Octavia, Head of Disease Prevention and Control Division. And I'm here to represent Dr. Vidya Stuti, the Head of Jakarta Provincial Health Office. Okay, like so many other cities represented in this conference, COVID-19 is threatening our fast-track progress. In March, our president declared a national state of emergency. And in April, Jakarta's governor introduced large-scale social restriction, which we call PSBB, that restricted people's movement, closes offices and entertainment places, and reduced HIV service accessibility. In terms of numbers, Jakarta has and continues to be hard hit by COVID-19. By early September, Jakarta reported close to 50,000 positive cases and 1,330 confirmed deaths. Testing rate, even though testing rate is 5 times higher than WHO minimal standard, that is 1,000 per million population per week, but positivity testing rate, despite increasing testing coverage, hit 13.2% in late August. And unfortunately, COVID-19 is disproportionately affecting young men and women between 19 to 40 years old, as you can see from the top image. The bottom image shows that confirmed fatality rates are highest among men, particularly in the 51 to 70 year age cohort. And before we move into the COVID-19 situation in Jakarta, I'd like to share Jakarta's HIV cascade up to June of this year through our fast-track efforts and refined size estimation. Jakarta is now showing that strong first 90 performances, with the majority of estimate people living with HIV knowing their HIV status. Not that there is some double counting here. Gaps in the second 90, although we have been collectively working to improve diagnosis, to provide rapid ART to all new people living with HIV and to support retention of people living with HIV on treatment. And acceleration in the third 90, where most current people living with HIV on ART have received viral load testing, are showing viral suppression rates of over 90%. As you can see in the light blue box section, HIV and viral load testing coverage fell dramatically in the period between March and early June, when the large-scale social restrictions were in effect. And to protect both health workers and the HIV service system clients from COVID-19, the Jakarta Provincial Health Office introduced new policy provisions in March 2020, while large-scale social restrictions were in place. We suspended community-based testing services and routine viral load monitoring. We move intervention like contact tracing of lost to follow-up people living with HIV to virtual channels. We continue static HIV testing, although many facilities had reduced clinic hours or assumed key roles as COVID-19 treatment facilities, and we prioritize two months ARV dispensing and home-based ARV delivery system services. Sorry. And to protect some of the fast-track gains and ensure continuity of treatment for people living with HIV, we introduced or intensified a number of program innovations, 4 of which I have included in this presentation. They are, one is expansion of 2-month ARV dispensing and introduction of home-based ARV delivery services. And the second is transition to TLD among the new people living with HIV. The third is utilization of going online strategies for outreach, case management, service appointment, and capacity development. And the fourth is provision of financial support to help people access health services. The first and perhaps most exciting for us is the introduction of home-based ARV services through a system we call Jack Antar. Jack Antar operates like this. The first client who is unable to come into a facility for services due to COVID-19 restriction has their address and mobile phone number confirmed by facility staff. Then the staff member contacts the client to ensure that their location is suitable for receiving ARVs. The ARVs are then sent to the client through the Jack Antar delivery system via a ride-based application or transport courier services, such as some examples of the businesses who give the transport courier service. The client confirmed receipt of the delivery with a phone message, photo, or WhatsApp correspondence. Finally, the ARV home delivery information is collected and processed by our implementation partner, USAID linkages. Both 2-month ARV dispensing and Jack Antar home-based ARV delivery were aggressively promoted and implemented during the period of large-scale social restriction. Coverage of 2-month ARV dispensing at 90 high-burden HIV treatment facilities rose from 12% coverage between January to March in 2020 to 69% coverage in the months of April to June 2020, despite a very insecure ARV or TLE supply. Jack Antar similarly rose to reach almost 5,000 people living with HIV by the end of June. Both healthcare providers and people living with HIV themselves have provided good feedback about the home-based ARV delivery initiatives. During April and June, Jakarta, with the support of the Ministry of Health and USAID, was also able to prepare facilities to transition to TLD, which started at the end of July for the new people living with HIV. While HIV testing and prevention service were limited during the large-scale social interventions, going online platforms such as the UNAIDS Ask Marlo chatbot, USAID linkages update status platform, and automated service booking system, and the GWL INA's Test Jakarta initiatives allowed key and priority population individuals to assess their HIV risk online, seek HIV prevention information, and make service appointments. From March to July 2020, for example, approximately 22,871 people went to update status, where 3,034 individuals assessed the HIV risk and 1,200 persons made online service reservation at various health services in Jakarta. Virtual community-based case management services have similarly played critical role in ART retention during the COVID-19 pandemic period. 6 of our CSO partners reported that they were able to increase the number of people living with HIV they supported between April and June, and they were able to help 99.9% of these persons stay on HIV treatment. Going online isn't just for programming through. We were able to mobilize WhatsApp to bring together all Jakarta HIV healthcare providers in weekly coordination or capacity session called BMW. Each BMW session introduced new policies or guidance, provided training on a technical focus area, and allowed healthcare providers to give feedback or test their knowledge. The BMW session have also helped us track healthcare providers that have been exposed to COVID-19 or have been diagnosed with the virus. And finally, we have intensified the provision of financial support to individuals who are having difficulty, perhaps because of the loss of their livelihoods, accessing HIV, TB, or other essential health services. One of these support initiatives, or JAC support, has received 400 applications in 1 month of operation and hopes to help about 650 people access and use health services over 2020. We have learned 5 key lessons from implementing fast track within the COVID-19 context. The first is enabling policy is key. Early into the epidemic, we introduced a circular that guided the provincial HIV response and helped to protect lives. 2, a pandemic can present an opportunity to introduce and test new program innovation. In Jakarta case, home-based ARV delivery service was an important way that we have kept people living with HIV on treatment, and we are moving to put this intervention into more formal and long-term policy. The third is using existing technologies can help people quickly connect to services, facilitate coordination, and aid in capacity building efforts. The fourth is while data recording and reporting systems are occasionally disrupted during large-scale social restriction, reviewing data quickly and often is helping us protect program gains, course correct, and flag problems early. Finally, it is critical that we continue to adapt our fast-track response to the new normal. In Jakarta case, we have drafted an HIV service protocol that establishes guidance and regulates services procedures from HIV testing to viral load examination as restriction loosen but COVID-19 endures. We will continue to review fast-track progress under this new service protocol in the coming weeks and months. Thank you for the attention.
Thank you, Dr. Octavia, for sharing your experiences of impact of COVID pandemic on Jakarta city, especially the HIV program. And you have shared with us your comprehensive approach in dealing with the HIV epidemic in city through various contact tracing through virtual media approach, as well as the unique JAC Antar and JAC support, including financial support to the vulnerable population? And how is it that you are going to having the way ahead to live the post-COVID live normal life? So thanks a lot for this presentation. And we would be next. We would be now having the presentation by the next speaker, Simon Ruth. Dr. Simon Ruth is Chief Executive Officer at Thorn Harbour Health, Melbourne, Australia. And I request Dr. Simon Ruth to start his presentation.
Okay, I'll just share my screen. Did that. Is that shared? Oh, God. That's shared, okay. Well, good evening, everybody. My name's Simon Ruth. I am the CEO of Thorn Harbour Health here in Melbourne. It's quite late here in Melbourne, so good evening. And it's 3 hours past curfew, which is an unusual experience here for us in Australia, where curfew is not something we've got a culture of. And I'd like to start by acknowledging the traditional owners on whose land we are meeting the elders of the Kulin Nations. So first, just to talk about Australia. Australia has a population of 25.5 million people. It is 90% urbanised. And so the concept of fast-track cities works quite well for us. 30% born overseas, which is a relatively high figure. We do have universal healthcare for residents, or where reciprocal agreements exist, such as with New Zealand and a dozen European countries. We have quite a complex healthcare system. Our federal government pays for primary care and for pharmaceuticals and GPs. Our state governments pay for hospitals, prevention, health promotion, mental health, alcohol and drug services, and there's virtually no role for city governments in our health system. And COVID hit us at the end of what was another unprecedented period. We had in the previous 12 months, we'd had 10 months of fires. And as many of you would have seen in the news around the world, we had 20 million hectares of land go up in bushfires in that 12 months, and almost the entire country was affected by that. Melbourne, in the map there, Melbourne is in the bottom right-hand corner, just above Tasmania. And Melbourne and Sydney, between us, Sydney's just slightly above us. We have about 50% of the population living in those two cities, and Melbourne is in the state of Victoria there. So, welcome to Melbourne. It's the home of the Australian Open Tennis, Australian Rules Football, Kylie Minogue, Kate Blanchett, and the various Hemsworth brothers. We have been a fast-track city since World AIDS Day in 2014, the same year that the IAS conference was here. Our cascade data is 89, 98, 96. That's 80% diagnosed, 98% on treatment, and 96% undetectable. We've previously been at 90% in diagnosed, but some modelling suggested we'd drop slightly. We have a population of roughly 5 million. Greater Victoria has a population of 6.5 million, most of the extra 1.5 million live in other cities in Victoria. We have a very strong partnership approach to HIV and to other bloodborne viruses. We have strong civil society with research, clinical and government all being key partners. And we also have a strong enabling environment for the work, particularly through civil society. We have had regulated sex work since 1984. it's okay to work as an escort and brothels are legal here. The Victorian AIDS Council, which is the former name of my organisation, was the first HIV/AIDS organisation in the country in 1983. And we've had needle and syringe programs widely available since 1987. So consequently, that's all led to reasonably containing the HIV epidemic quite well. New cases in Australia are 90%, in Victoria and Melbourne are 90% male. The majority of those are men who have sex with men, and of the cases that aren't men who have sex with men, about 50% of those are new arrivals into Australia who arrive with HIV. We have strong PrEP uptake amongst MSM, and we have a strong health promotion approach. That is an example of a testing campaign there, which is currently out in bus shelters and train stations around the state. I drive past that poster on my way to work every day. Tuberculosis isn't something we tend to talk about much in Melbourne. It's not something that there's a lot of local transmission of, and it's mainly temporary migrants, overseas students and the like who are diagnosed with tuberculosis. Now to COVID. So that's Australia in the top left-hand corner there in the red, and Victoria, or almost entirely Melbourne, in the top right-hand corner. And you can see the other 7 territories from around the country, the other 7 states and territories. And this one, it's a bit like that Sesame Street. One of these things is not like the other ones. Every other state and territory peaked in March, with travellers returning from overseas and a bit of community-acquired COVID. Victoria did incredibly well in March. You can see we only have a very slight peak there in March. But then we lost control in early June. And there was a failure to contain the virus in a quarantine setting, and consequently, we've had a very significant amount of community transmission occurring. That's just another view of the epidemic in Melbourne. So you can see we're on the right track there. That goes up to yesterday. At our peak, we had 725 cases in one day, and we're very thankful that we're on a decline. Again, that's another view of Victoria and Melbourne. So for the policy response, we had our first case in late January, which was a traveller, but we went into a state of emergency on the 16th of March. We had early restrictions focused on social distancing, which were enforced immediately, and restriction on gatherings in the home and in public. We strongly encouraged people to work from home if you can, and that was reinforced by a union movement, an organised labour movement. We followed in late March by enforced closures of many workplaces. So in late March, restaurants, entertainment venues, bars, brothels, gyms, cinemas, schools, hairdressers, beauticians were all closed, and airlines were grounded. And many of those businesses have not opened since. So we're currently sitting at 5.5 months, and there's a significant number of people who've been unemployed in that time. There are some financial support programs available for businesses and for individuals, but they're largely focused on permanent residents and citizens, so they don't meet the needs of the entire country. We have had an international travel ban since the 17th of March, so residents and citizens cannot leave Australia without permission. We've had mandatory quarantine for people returning to Australia since late March. There was a short period of easing restrictions in June there, but then the second wave hit in early July and the restrictions were reimposed. At one point there were several public housing blocks which went into a complete lockdown, which was incredibly controversial because people weren't allowed to walk out their front doors. And that was in Melbourne's inner west, and then within 2 or 3 days, the rest of Melbourne went into a stage 3 restriction. So a bit more on the timeline. So around that time, New South Wales closed its border to us, and that was the last border. So if you live in Melbourne right now, you cannot travel anywhere in Australia. Every other state has its borders closed to us. As the numbers continue to rise, 3 weeks after that occurred, it was announced on August the 2nd that we're moving to stage 4 restrictions, and that they would occur for 6 weeks to the end of next week. And so here we remain. So we have a curfew from 8 p.m. to 5 a.m. We have work permits in place. Only essential workers are allowed to leave home for work. And essential workers are healthcare, emergency services, the press, and people who work in food supply or food chains, so groceries, home deliveries, restaurants, etc. You're not allowed to travel more than 5 k's from where you live. It's mandatory to wear a mask if you're outside. If you live in Melbourne, you cannot leave Melbourne, so you can't travel elsewhere in Victoria. And there is an enforced border around the edge of Melbourne. There's only 4 reasons that you can leave home, and that's to shop for groceries, for 1 hour's exercise a day, to receive or give medical care, or if you're an essential worker. You can visit your intimate partner if you don't live with them, and healthcare is still relatively open, so needle and syringe programs are still available. Primary care is still available, but they encourage you to seek telehealth mechanisms if you can, which we've already heard about. And last Sunday it was announced that stage 4 would continue until the end of September, and they delivered a roadmap for recovery that would take us through to December. A lot of people didn't take that well, but there is a 70% approval rating for these measures in the state. And with the exception of 2 weeks in June, we've now pretty much been in lockdown for 6 months. Many people have not worked since March, and for many of those people, they are facing not working until December. And for communities like the LGBTI community, you know, there's a significant loss of community infrastructure. Bars are going bankrupt, other venues, sex on premises venues are going bankrupt as well. So it will be a difficult time when we reopen. That's today's figures. So there were 51 new cases today, down from that peak of 725 a few weeks ago. Almost 20,000 cases in total in Melbourne, 2.5 million tests since March, and 701 lives lost. Of the cases, you can see there the age distribution. Slightly more than 50% of the cases are female, slightly less are male, and the vast majority of the 700 deaths feature in that group over the age of 70. So the outbreaks. So what do we know about the outbreaks? So as far as we know on ethnicity and socioeconomic factors, we haven't had a lot of research into those yet, so it's a bit unclear, but there's some things we do know. Overcrowded housing has been an issue, both public housing and private housing. Prisons have been an issue, again, but due to the inability to socially distance within a prison setting. Essential workers have featured in the data as well, particularly those in low-paid service industries, such as meatworks, fast food, groceries, and all of those are jobs where we know there's greater exposure and higher risk. Roles, there are also roles that are likely to feature people who are migrants and who have poor English. There have been aged care outbreaks, significant for both staff and for people living in aged care settings. A lot of talk about low-paid workers being hit by the virus more than wealthier people, largely due to overcrowding and living situations. And there was a bit of a media frenzy because our safe injecting facility is open past curfew. So there were questions about how you can attend a safe injecting facility if it's after curfew. That is the front page of one of our Melbourne papers that came out the day after every other state closed their borders to us. So as a HIV response and as a civil society organisation, we focused early on areas of overlap, and one of those we began messaging about casual sex being a risky activity. Our messaging was via social media and apps, Grindr, Scruff. We went into community print and radio. We put out street posters. We released messaging in 8 community languages. And coupled with the closure of sex on premises venues and many of the apps also providing messaging to avoid casual sex as well. Our prevailing message has been, it's not going to be much longer. We're all in this together, but after 6 months, messages around avoiding casual sex are just starting to lose their resonance a bit. And it is the first time in the history of our organisation, which started as a gay men's movement, that we have encouraged people to have less sex or not have sex. So it is a challenging message. The 2 ones on the right there are from one of our community event-based companies who wanted to put out some community messaging with us around resilience and focusing a bit more on mental health. So BBV and STI trends. The outcome of restrictions and messaging about sex has been an overall reduction by 33% in BBVs, bloodborne viruses and STIs between April and June, and a 13% drop across the year. The clearest one there is gonorrhea. There's been a dramatic drop-off in gonorrhea, possibly some reduction due to difficulty getting tested. Our rapid point-of-care testing service, which is run by community, has been closed for much of the lockdown periods, but most of our clinical testing is still available. There is a study into MSM's sex lives called the Flux study, and that was about drug use and sex, and it's pivoted very quickly towards COVID. And what they found was the men in their study had reduced their casual sexual partners by 85%, or 85% of the men were avoiding casual sex and casual hookups and were only having sex with regular partners. There's strict physical distancing has impacted on all infectious diseases, and similarly, we've just come out of winter and there's been virtually no influenza this year. That's just another graph of the same data, but you can see the very dramatic drop off there that starts around late March. A reduction in sex has also seen a reduction in post-exposure prophylaxis use, PEP. In Melbourne, MPEP data for the previous 12 months there, significant drop-off. MPEP's largely available through hospitals. We have been discouraging people from going to hospitals because we haven't wanted the virus in there, but you can see there around April to July, there's a significant drop-off, a slight bump in June, and we did open up for those 2 weeks in June. And then to PrEP, so we've seen varying studies reported 25 to a 40% decline in daily PrEP use. In this one study here, which was self-reporting, men self-reporting their PrEP use, 1 in 4 men suggested that they weren't using PrEP. Another study that looked at prescribers said they'd seen about a 36% drop in prescriptions for PrEP between April and June. A group of those men, the figure of 8 there in the light grey, is men who reported moving to PrEP on demand or event-based PrEP. And most of the men who stopped were saying that they stopped having casual sex during COVID-19 and they decreased the number of casual partners. And if you head right down the bottom, there was some fear about possibly picking up COVID if you were out. For many of the men, this will be the first time they've had a break in PrEP. We've had PrEP available on the public system for 2 years, but available more broadly for 5 through research trials. So a lot of people have not ever had a break in their daily PrEP use. So this is quite a change in the pattern of use here. We have had reports of 1 or 2 transmissions of people who started reinitiating sex before they've reinitiated PrEP. So my organisation is currently focused on delivering messaging about recommencement of PrEP and educating people about how to use PrEP on demand and event-based PrEP. More broadly, issues. There's evidence that government messaging was inadequate with migrant communities and non-English speaking communities. There's been confusing messaging about sex and sex work. Leaders who either didn't understand the various types of sex work or were too embarrassed to discuss it publicly, so that was quite confusing. And of course, after 6 months of saying no casual sex, that message is starting to get a bit of fatigue. So we're trying to look to develop harm reduction based messaging around sex that is useful, but doesn't conflict with the law or create a narrative of gay men breaking the law and creating stigma associated, similar to what we've seen in HIV. As I said, long-term unemployment or underemployment's created a range of problems. There's a general community belief, even though there's support for the restrictions, there's a general belief that government needs to be doing more for business and individuals who've been unemployed for long periods. And for some community members, particularly those who've been at increased risk, they may have actually been staying at home for the last 6 months. So we're seeing issues of loneliness, depression, anxiety, suggestions that suicide has increased. And of course, the inability to travel either interstate or internationally has meant that a lot of people have been unable to see loved ones as they've passed. And so there's grief and loss associated with that loss of opportunity and the chance to say goodbye. For the HIV and the hepatitis C response, one of our biggest issues is that the co-option of our scientific and medical leadership across to the COVID response. We've had multiple projects around our HIV programs that we were intending to roll out that have just basically been put on hold since March as the Doherty Institute and Burnett Institutes have moved their focus across to COVID, and other systems like setting up car-based testing when it's the only option for a suburban area, but if you don't drive a car, you can't access testing. So that's been problematic. And what has worked? So innovations and programs have been many and varied. Government quickly deployed telehealth, so you can get free medical GP appointments and counselling, and that has removed location and distance as a barrier to care. This adaptation would have taken years otherwise because of the prevailing view that people wouldn't like it, but it's rolled out very quickly. It's actually seen an upturn in attendance, but we've also seen a 15% drop off in people following through with viral load testing, so we need to look at how we get people to follow through on getting patients on getting their pathology done remotely. There has been a little bit of deferral of counselling, people saying they don't want to be counselled until they can get face-to-face services, and we certainly need to do work around who's missing out. So we've made assumptions that it's older people, people with less English, people in disability communities, but we certainly need to survey that and back it up and look at usability and satisfaction and focus on quality of life in a new environment for key affected populations. There's been some great innovations, particularly in opiate pharmacotherapy response. Previously, if you were well behaved, you could only get 2 takeaway doses a week. Otherwise, you need to attend every day for supervised dosing. The government has freed that up so you can get 6 to 14 takeaway doses per week. It does require you to get both your pharmacist and your doctor to agree to that. A third party can collect those doses for you, which is new. And previously appointments had to be monthly based with your doctor, and now doctors are allowed to write longer scripts. So that's been a definite benefit, and it's challenged that ongoing myth that drug users can't be trusted. We've solved homelessness currently. All homeless people in Melbourne have been housed since April to prevent the spread of the virus. That has created a bit of an issue for government, as they didn't have an exit strategy when they put everyone into hotels. But we're all hoping that, you know, we have proven now that homelessness is solvable, and so we're hoping that we can continue that. Education, we've certainly moved quickly into new mediums and providing new messages. There are many new service offerings and volunteer opportunities, particularly around social supports, home-based care, online engagement programs and forums. And we'd hope that, you know, most of these changes are here to stay to either a greater or lesser degree, as they've all been incredibly positive and client-centred. And that is a poster there looking at pharmacotherapy changes for the advocacy service. And finally, I just want to thank, you know, the Melbourne Fast Track City Partners, Victorian Government, City of Melbourne, Doherty Burnett, our 2 POSORGs and Thorn Harbour, and they are the photos of the people who supported me in pulling this presentation together, as I'm probably the least qualified person in our partnership to actually deliver this presentation, but I hope it was beneficial.
Thank you, Simon Ruth, for an excellent presentation and in-depth analysis of COVID trends, including the route of transmission, the control and containment measures that have been taken by your city and in the Victoria province. The second wave that has been shown for COVID in your city has been different from all our metro cities experience, because we are still trying to contain the first wave in our areas. And the various innovative strategies that you have used, and for community messaging as well as for uptake of PrEP during the COVID times, or the takeaway dosage for drug users, are some learnings that we can take up and take it ahead. I sincerely thank you for sharing your experience for Melbourne City and Victoria Province. Thank you.
Thanks.
I would like to thank all the presenters, Dr. Thitishant from Bangkok, Dr. Octavia on behalf of Dr. Vidya Stuti from Jakarta, and Simon Ruth from Melbourne, for having an excellent presentation about their city experiences in managing COVID, as well as its impact of COVID pandemic on the health programs of HIV, STI, hepatitis B, and what are the different innovations that they have tried in managing and ensuring continuity and retention of care for the patients affected with HIV/AIDS, the various vulnerable groups, whether it is the home delivery system using virtual media, virtual appointments, social media approaches, or whether it is financial support and collaboration with the pharmacies. I thank IPAC for giving us this opportunity to present the experiences from the cities in Asia Pacific region and learning from each other's experiences to continue with our efforts in the post-COVID times, the new normal, as we say, and how do we continue to not have the significant impact on the various non-COVID diseases because of the diversion of health and other resources in managing COVID pandemic. Thank you. Your efforts and innovativeness is really very encouraging and stimulating. Thank you.